All right. Thank you for joining us this morning. And it is March. So, this is all about colorectal cancer awareness month. So, we are empowering all of you to stay ahead of it through screening colonoscopies and early detection because it really does save lives. And I'm so thrilled to have join me this morning Dr. Nicole Sauer. She's a colorectal surgeon at the Hartford Healthcare Digestive Health Institute. Let's give her a warm welcome.
Thank you so much. And thank you all so much for being here. I'm really looking forward to the discussion. I know we're going to have some time at the end, but we really want this to also be informational for you. So please do raise your hand and ask any questions as we go along. And thank you again for being here.
Yeah. I just want to start out with some of the warning signs when it comes to colorectal cancer. What should we be looking for? What should alarm us?
Yeah, good question. So first of all, colorectal cancer, when it starts, it's asymptomatic. And so that's the, sort of plug for later in the discussion about screening. But when it becomes symptomatic, it's often rectal bleeding, changes in the stool caliber. So maybe it's more narrow, maybe it's just a different consistency than what you're used to. Also, the stool can be black or tarry. Abdominal pain, cramping, weight loss, fatigue, those are some of the symptoms. And, because they are sort of non-specific, except for the rectal bleeding, sometimes it can be a bit difficult to understand what is causing those symptoms. So again, being on top of your screening is really the best way to prevent the colorectal cancer.
When it comes to bleeding, if you should notice blood in your stool, does the color matter?
N n Not really. So, no bleeding is normal. And so, I see patients a lot for hemorrhoids in my office and, we say, "Okay, this could be hemorrhoidal bleeding because it's the typical sort of bright red blood, but no bleeding is normal." So, if you have hemorrhoids and you're treating your hemorrhoids and you're still having bleeding, that's when we get a colonoscopy or we do further workup because it doesn't matter what the color is, it's not normal. It can be from something other than a cancer, but we wanna be treating that.
So we hear colon cancer and we hear colorectal cancer. What is the difference?
Yeah, so the colon is the beginning of the large intestine, which is situated in the abdomen. So kind of makes an upside down U in your abdomen. And it's sort of free floating in the abdomen. So it makes it a little bit different to treat than rectal cancer, which is situated in the pelvis, which is a very narrow area below here. And that is immensely integrated with other structures like important blood vessels to the legs, the uterus in women, the bladder. And so the rectal cancer becomes more challenging to treat sometimes just because of the location.
Talk to me about screening. Obviously, screening is so important, and we stress that not only this month for awareness, but all year long. You should be getting screened. How often should you be getting screened?
Yeah, so screening, the age has started now at 45, and now it goes until 75 when it becomes personalized. And then between 75 and 85, it really depends on a discussion with your physician. I always tell people if you're planning on living another 10 years, then you should have a colonoscopy because we want to prevent colon cancer. And so if it generally, if your body follows the textbook, if your polyps follow the textbook, it takes 10 years to go from a polyp to a cancer.
You're planning on living till 200, right?
Yeah. Yeah, so that's the interval. If people have a family history, then we start sooner. And then the screening colonoscopy is for people that are asymptomatic and don't have polyps. Once you have a polyp, it becomes what they call a diagnostic colonoscopy. And then that interval depends on how many polyps, what the types were, etc. So whenever you have a colonoscopy, either the day of or after the pathology comes back, the endoscopist will tell you when to have the next colonoscopy. And that's important to make a note of with the, EMR, the electronic medical record becoming better. We have the My Chart, of course, at Hereford Healthcare. It becomes easier to get these reminders, but it's also just good to have that in your mind when you're due for your next colonoscopy.
Can polyps turn cancerous?
Yes. So there's two types of polyps. One kind is called hyperplastic, and that is a benign polyp. So that polyp can stay there forever. It will never turn into a cancer. There are other polyps that are called precancerous or adenomatous polyps, and adenomas turn into a cancer over this, again, if we give a general range, about 10 to 15 years. And so those are the polyps where if we remove them before they turn into a cancer, then we can prevent the cancer. And that's really the great thing about colonoscopy is that it's one of the only screening modalities where you can diagnose a cancer, but you can also prevent a cancer by intervening at the time of the procedure.
Ha are are some people more prone to getting polyps than others?
Yes. So there is a genetic component. And so we know that if you have a family history of polyps or a personal history of polyps, that's when you end up having a closer interval for your colonoscopies. So there is a genetic component, there is an environmental component, and we'll talk a little bit about sort of what you can do to decrease your risk. But there is an environmental component as well. And that's why the interval between colonoscopies really is personalized because it depends on your risk based on your past colonoscopies.
Yeah. How many of you have had colonoscopies? If you every hand should go up, right? How about
Wonderful.
polyps? Polyps removed, yeah. So, polyps are common, right?
Yes.
To have them, removed at the time of the procedure?
Yes. It depends. It's different between men and women, but we are supposed to be finding adenomas in about a third of our colonoscopies, and that means that we're doing a good enough job finding the adenomas. It's one of the metrics that we use to tell ourselves if we're doing good enough quality for our colonoscopies. So it is common.
Mhm. And in terms of screening, the statistics, because I just wanna stress how important it is to have to be screened for colon cancer. Talk about some of the statistics in terms of screenings, in terms of finding cancers, and why it's so important to get screened.
Yeah, so we know that colon cancer is the third leading cause of cancer diagnoses in both men and women, but it's actually the second leading cause of cancer death. And so the we have that opportunity to intervene. And like we said, we about a third of the time we're finding these adenomas, which is an opportunity to prevent a cancer. And when the adenomas get larger, we know that they will turn into a cancer, but as they get larger, then it becomes more challenging to remove them. So sometimes we have to do surgery for patients who don't have a diagnosis of a cancer, but they have a precancer that can't be removed. And so we know if we leave it there, it will turn into a cancer. So the earlier that we're identifying these, the better in terms of being able to safely remove them.
And let's talk about the of course, the prep process.
Mhm.
That's always popular, always a popular topic. You all can't wait for that. People look forward to that. Said no one ever. The prep process, though, it has gotten better. It has over the years, right? There are different sort of prep methods, if you will. Can you talk a little bit about that process?
Yeah. So the trade-off is you have a prep which may not be the most pleasant, but then you get a really nice 30-minute nap, very reminiscent of a spa day. And so the prep, you can't get around the fact that you have to clean out the colon. And so all of the preps are going to result in a decent amount of liquid diarrhea because that's the whole point is because we have to be able to see. And it really has to be the consistency of water because then we can suction. If there's a lot of particles, we're talking about polyps that when we're trying to find them, they can be anywhere from 2 to 4 millimeters is the kind of a typical range. And so if there's a speck of stool that could be obscuring a polyp. And so unfortunately, the reality is we have to clean out the colon. So it used to be this really large jug of gross lemon lime flavored material. And universally nobody liked that. And that was actually basically like a gallon jug. Now most people use a Miralax, which is tasteless. You can put it in any type of liquid that you like, Gatorade, Crystal Light, even iced tea. And as you're doing the prep, something also that people find helpful is to try to take liquids with protein. So like bone broth, or they have like a boost or an Ensure that is clear, a protein drink, because then it helps with you feeling more full. Because the other problem is, you're having a day where you can't eat probably inevitably you're watching television, and then there's food ads every other ad, and so that part is also really challenging, so that can be helpful. They do have now pills that you can take. For me, I just find the pills are kind of tough to swallow, literally, and then you also have to drink so much liquid to sort of flush things through. And so, everybody has their preference. My preference is just regular old over the counter Miralax. And if you split it into 2 doses, it's been found to be more effective. And you only have to drink 64 ounces of liquid. And again, you can do any liquid that you like. So it really is palatable. I've actually done it myself, and I can say it really is not, it's not too bad.
The other good thing about having a colonoscopy is when you're done, you can have a meal. You can eat whatever you want, after that spa-like experience of being under, right? So a couple of things to look forward to there. Let's talk about some of the at-home tests that are available. Your thoughts on that? Those seem to be pretty popular among people, but is are there a lot of false negatives, false positives with those? And what's your take on that?
So there's 2 different tests. One is a test looking for blood. And so, of course, that one is not as sensitive because you can have blood from hemorrhoids, you can have blood from irritation or what they call colitis. And so, it can be helpful because if you don't have blood in your stool, then that tends to be a pretty good predictor that you don't have an advanced polyp, meaning a large polyp that's about to turn into a cancer, and you don't have a cancer. The other option is, I'm sure you see on TV all day long, this Cologuard, where you just get the little box with the legs on it and it comes, to your house and you send it back in. That actually is a stool DNA test. And so that's looking for these advanced polyps and the cancers that are shedding DNA. So it is more sensitive. It is able to predict cancers better. There we always say any screening that you are going to complete is the best screening. So for an individual person, the colonoscopy is the best because we can both diagnose and prevent cancer. And so if you have a positive on any of these other tests, then the sort of end point in the algorithm is to get a colonoscopy. And so for me, as an individual patient, I would say I'll just cut out the middle person and just do the colonoscopy. But when we look at our population level, we want to make sure that we don't have any patients that are getting nothing. And so that's where these other tests are helpful because if you say, well, I'm only willing to get a colonoscopy if I know that I have blood in my stool or I know that I have this DNA, then those tests can be helpful. But I think if you're able and willing to get a colonoscopy, that still really is the gold standard.
Dr. Sauer is a colorectal surgeon at the Hartford Healthcare Digestive Health Institute. Dr. Sauer, talk to me about the Digestive Health Institute. This is a place where you can go and literally get all of your care under one roof in the same place. It's highly personalized. When we say that, what does that mean?
Yeah, so we have an integrated care model. And so that means all of your specialists. So let's say you were meeting me because you were diagnosed with colorectal cancer, or let's just say colon cancer. Then we would complete the staging. We would sort of understand what kinds of treatment you needed based on the cancer. But we're not just thinking about the cancer. We're thinking about you as a human, as a patient. And so we want to know what other medical issues do you have? What other vulnerabilities do you have and what are your goals? So what means the most to you? What would be the best pathway based on what your preferences are? And so we have an entire team that we work with. That could be nurse navigators, that is all of the specialists, oncology, colorectal cancer. We have a really great group in what they call pre-admission testing, where they help people get ready for surgery. So maybe you need to have a look at your heart with a special ultrasound, or maybe you need physical therapy to get stronger before you have surgery, or nutrition optimization. So these are all things that we can do in a personalized way with our care team. And it really is seamless. And thanks to the navigators, everything is sort of laid out. And that's something that I think is really important when you're starting on any kind of journey with any new diagnosis, to have the information that you need, but also have the teammates that you need in place and know who you can contact.
Yeah, the nurses, I want to always give props to the nurses. They do such a tremendous job in terms of navigating so that if you are diagnosed, you really don't have to worry about appointments, anything. That's all taken care of through the nurse navigator. They're really there with you step by step to help you through what can be a very difficult process. Let's talk about the treatments for colon cancer. If you do get to that point and you need surgery, what can you expect at the Hartford Healthcare Digestive Health Institute?
Yeah, so the treatment of colon and rectal cancer is based on the staging. And so in the early stages, surgery can be curative. And so that's why we really want to catch these when they're early. When they're in a more advanced stage, then sometimes we do chemotherapy, or in rectal cancer, chemotherapy and radiation before the surgery. And then sometimes, based on the pathology, we actually do chemotherapy after the surgery. But really, surgery is a mainstay still in colon and rectal cancer, because the most important piece, especially in the early stages, is to remove the piece of the colon and the associated lymph nodes, because we know that colon cancer spreads through the wall into the lymph nodes and then eventually elsewhere. And so that's the reason that we want to understand the status of both how deep it goes into the wall and as well into the lymph nodes, if at all.
And what's the recovery process like?
So we can do minimally invasive surgery now. All of our surgical techniques have become much more sexy, but it's still major surgery. So we still say, 4 to 6 weeks for recovery. And that doesn't mean that you can't do things. You can do anything. The only things you really can't do are heavy lifting, nothing more than about 50 pounds, and driving. We don't like people to drive for the first 2 to 4 weeks, just because you will have some incisions on your abdomen, and you probably won't be as quick on the brakes if you're trying to protect your abdomen. And so those are really the only true restrictions. But people tend to, need a midday nap. They need to take it easy, have a little bit of TLC from their family. And so we do say 4 to 6 weeks, but generally people spend anywhere from 2 to 3 days in the hospital, and the rest of the recovery time is at home.
And when you say minimally invasively, just explain that a little bit. Is that quicker recovery, less blood loss, smaller incisions?
Yeah, so that's where we use the camera and the small instruments. We blow up the abdomen with carbon dioxide. And so then we can see around and do all of the work that we need to do with just the camera and the small instruments. So it saves from the large incision, which is painful, but it also, a lot of times when we do that kind of thing, the small intestine shuts down. People get what they call an ileus, where it's harder to eat and drink. And that's what historically kept people in the hospital a long time, because they were waiting around 5 to 7 days just to have a bowel movement. And now, basically, because we don't have to manipulate the bowel as much, people can get home with less pain, shorter hospital stay, a quicker recovery, quicker return to whatever it is that is most important. And besides colorectal surgery, my other expertise is in what we call prehabilitation. And so that's this act of getting patients ready for surgery. So I'll just put a plug: if you had any surgery, even from a very small surgery that you go home the same day to major surgery, the biggest things that predict the outcomes are basically revolving around this opportunity. Just like if you were training for a marathon, right? You wouldn't just go and do that without any preparation. It's the same thing for surgery. So we like to make sure that your nutrition is optimized, that your activity is optimized, that we understand what your goals and your wishes are. And that's all part of this prehabilitation process. And so, like I said, that's one of my passions. And that, I think, is really important as you undergo any kind of procedure.
So that's interesting. So whatever it is, so how does that work now? How do they get in touch with you? And this is something unique that's offered at the Digestive Health Institute?
Yeah, so we have, as part of Hartford Healthcare's Digestive Health Institute, we have this pre-admission testing, and that's where everybody goes to get an evaluation, the labs, EKG, all of the things that you typically get from a pre-surgical visit. But we also have the opportunity to focus in on these things like nutrition, physical activity, and that can be really important. You can also partner with your primary care physician. So, if you do have to have a procedure, a big one is orthopedic surgery, for example. Sometimes if you come in with a fracture, you're not going to be able to get this rehabilitation. So you're going to be focusing on rehabilitation after the surgery. But if you have something that is, needs surgery but doesn't need it immediately, that's this opportunity. And you can partner with, of course, the surgical team, but also with your primary physician to make sure that these other aspects are optimized.
Can you just expand a little bit upon immunotherapy? That's so important. It uses the body's immune system to attack the cancer cells, right? Can you
Exactly.
explain that process a little bit more? Because it's fascinating.
Yeah. So basically there's this concept called the tumor microenvironment. So that's all of the cells and the bacteria that are sort of living in and around the tumor. And so like you were saying, you can use the body's own immune system to identify the tumor as abnormal and then basically treat it itself or attack it like it would to a foreign invader. And that's the thing about cancer is that cancer is foreign cells, but it sort of tricks the body into thinking that it's the host. And so then the body is using its resources and its blood vessels to sort of grow the tumor. And so that's the really unique piece about immunotherapy. And it's evolving. Even in the last 2 years, we've had a lot of change. And so I think it's going to continue to expand and that's another piece about we do a lot of work in colorectal surgery looking at the microbiome. You guys are probably hearing about this when you think about like eating yogurt and probiotics, but there's a big component of the microbiome in how patients do after surgery. As colorectal surgeons, we think of ourselves a little bit like plumbers because we hook the colon together and then we, hope it doesn't leak, but there is an aspect where it can leak. And so, historically, we always thought that the leaks were because the plumber wasn't doing a very good job or there was something wrong with the plumbing. And we find out that there's actually bacteria that live in the colon that can actually break down that connection. And those same types of bacteria are associated with different outcomes in cancer care. And so that I think is also sort of a really important advance. And so one of the things that we didn't talk about too much, but that is important in treatment, but also in prevention is diet. So, high fiber diet, high protein diet, avoiding processed meats, avoiding alcohol, avoiding tobacco, because those things can affect the development of cancer and it also can affect the treatment.
I do want to mention that just recently, Hartford Healthcare became concordant with MSK, Memorial Sloan Kettering, as a care partner. And what that means is that we follow the rigorous standards of MSK right here in Connecticut. So you don't have to travel to New York to get that same level of care at MSK. So, Dr. Sauer, can you just talk a little before we wrap up? I think this is really important. Can you talk a little bit more about what that means for the patient?
Yeah, so like you said, we're all following the same protocols just to make sure that we're staging appropriately, that we're treating appropriately. There's also opportunity for clinical trial involvement. And so it really is a collaborative model. And I think a really unique, I know Hartford Healthcare is the first care partner with Memorial Sloan Kettering, and really a unique opportunity to have the same care that you would get in the city.
That'll do it for today. Thank you so much. Thank you to Dr. Sauer for some great information.
Thank you
And
for being
thank you to
here.
all of you. We will see you back here next month. Have a great day.